Jessica Miller from the University of Maine, where I'm the chair of philosophy. This has been a really wonderful experience at the forum. I would like to thank Susan Mizrahi and my fellow panelists and everyone who participated last night. That was a wonderful session as well. I feel very privileged to be here. I thought I would take the opportunity to actually reflect on disciplinary questions a little bit. I got into clinical ethics consulting shortly after I moved to Maine, and that's kind of another hat that I wear in the local healthcare system, which actually, because it's Maine, covers 2/3 of the state. So I wanted to talk about a particular patient and a case that I intersected with at one point. Okay, so we're talking about the way that humanities can address the opioid crisis. And I'd like to start by sharing some perspectives on philosophy and then on clinical ethics. Lay people often think of philosophy as a kind of creative, freewheeling approach, right? Sit on a mountain with a beard and stroke it and think about the meaning of life. And then I get these amazing papers from my students where they have this playful and creative attitude, things like, you can't do that. Right? If I had a nickel for every ethics paper I got with that title, I would be a rich woman. But I was taught very differently in my graduate career that philosophy is careful, consistent, critical reflections on a set of problems that the discipline defines as philosophically significant, like causation, time, mind, consciousness, free will. The strongest philosophical arguments are ahistorical and disembodied. Clear definitions and precise expression, coherence and hanging together with other beliefs are the hallmarks of good work in the field. In philosophy, what goes along with that as a way of doing it is that we tend to think the best way of evaluating philosophical work is by subjecting it to the strongest or most extreme opposition. This culture of justification is so strong in the field that even while we are thinking and writing in our offices or our home offices, we are to imagine skeptical opponents whose well-placed objections could demolish our entire argument. And this is what Plato and the Meno called heuristic discussion, a way of doing philosophy that aims at the victory of one disputant and the defeat of the other. Well, this is very different from the world of clinical ethics consultation, which, although it's still in its infancy and still it has many competing understandings, actually, of what it's all about. When I started in the Wild West of the early aughts, there were few degree programs, no comprehensive national organization, no credentialing or licensure. Clinical ethics could be done and can still be done by philosophers, nurses, theologians, sociologists, lawyers, doctors, psychologists, social workers, and more. So it doesn't have the same legacy of kind of a pretty high barrier for entry that philosophy has, with a lot of social implications, by the way. So there remains an elasticity about who can do clinical ethics, how to do it, and even what it is that I have found very exciting in my own work. Although, of course, it is not magically free from all of the injustices that beset entry to other fields like philosophy. So in philosophical ethics, we focus a lot on moral judgment, moral action. We carve up our moral lives, into pieces and snapshots that are pretty static. Anglo-American ethics in particular is notorious. You can tell that I'm not like a Merleau-Ponty scholar, right? Because I'd be saying very different things about philosophy. But I have an Anglo-American education, which is pretty mainstream in the US, designed to tease out our moral intuitions. So we use thought experiments. They're supposed to tease out our moral intuitions. The logical consequences of our different moral theories. So early in my career, when I would give my students the trolley problem, which many of you are probably familiar with from many different disciplines, they would ask me why no one else was on the trolley, and had the brakes ever stalled before, and why are 6 workers having lunch on the track? And I would say, well, this is irrelevant. Why can't you abstract away from meaningless detail and focus on the logically relevant and morally relevant parts of the example? We have to get our ethical theories straight, and then we can reintroduce all the mess that human life brings, was sort of how I was trained to think of this. But in contrast, in clinical ethics, the details are the case. there's no case without a patient. And the patient comes with all of the uniqueness that every one of us comes with. The work is done by coming to understand their personal stories, their unique stories, their subjective experience, along with those of the other members that are involved with the healthcare team, their family, et cetera. We have a strong sense in clinical ethics of being in the middle of a story, not outside a story, evaluating it. It's reinforced when we're in meetings by the sound of codes called on the intercom, the whiz of beds by the conference room, everyone's beepers going off, and something I had to get used to very early on was not taking personal offense when people stepped out of the room during ethics work at the hospital. The moral work here is forward-looking, not backward-looking and assigning blame. It's defined as working out together the most ethically supportable way to go forward. Ethics is something we create together, not something we discover in the cool hour, separate from the mess, and then apply. When people ask me, therefore, how my philosophical training has helped my clinical ethics work, I often reply that it gave me a ton of stuff to unlearn. And I'm only half joking. The adversary method is totally unsuited for the realm of acute care where most of my consulting takes place, although increasingly I'm working with outpatient folks where people are vulnerable, anxious, and upset. The goal in clinical ethics is practical, not theoretical. As a clinical ethicist, often people think, oh, here comes the ethicist. It actually says it on my badge, right? You're going to judge, right? You're going to, here's the cop, and you're the judge or the cop or the something, and it's not that at all. It's really more ethics mediation. It's working with a group of people to lend my bit of expertise to help them move forward in a difficult situation. I'm trying to help people make progress on a challenge that faces them. Sometimes I feel like a plumber trying to break up a clog to allow the patient's course of care to flow freely again. Sometimes I feel like a contractor who opens up moral space. It's very hard to do that, particularly in acute care where everyone is too busy and has too much to do. It's even physically hard, like finding a conference room. It's very easy in the academic setting. And we think about the architecture of ethics. We have lots of open spaces like these, right, for having these kinds of conversations. In the hospital, I'm banging doors, and we find a room, and 2 nurses are having lunch in the corner, and a bunch of old equipment is in the corner, and somebody needs it in 15 minutes, and so it's very symbolic, I think, of the challenge for reflection in that particular space. Okay, so I'm engaged in a social process of moral negotiation and mutual accountability. My own work in Maine began about 4 years after Purdue released OxyContin, marketed as a safe, continuous, that's the contin, right, form of pain relief for many kinds of pain, as of course a major driver of the opioid epidemic. We know that Appalachia, Midwestern Rust Belt counties, and rural Maine were some of the earliest adopters of Oxy as a way of life. Working class families who are dependent on jobs that are subject to high-risk injuries, logging, fishing, mill work, lived where the treatment options were often many hours from home. This is a big issue in my part of central Maine. Doctors were told by drug reps that Oxy had less than a 1% rate of addiction. That less than 1% rate was repeated over and over and over again. In the early years, it had no evidence backing it up. I think it came out of a letter to the editor in JAMA or something. And over dinner and drinks or on a golf course in Hawaii, they believed it. So we have to also look at the way that morality was important, though, in the prescribing. Moral discourse and morality is not separate from society. It's one of our social practices, and people were told, and they believed it, not just for the sarcastic reasons I mentioned about the lobster and the golf course, but because they believed that pain was the 5th vital sign, and we were going to help these people. And it's not only okay to do it; it's the right thing to do to prescribe this. Doctors and hospitals were just accrediting the 5th vital sign, or looking at that, developing new standards for pain assessment and treatment. We were supposed to think of pain as just like blood pressure, heart rate, respiratory rate, and temperature. So the rise in painkiller misuse in the 2000s led to the tightening of prescribing practices. Maine began with a statewide database known as the Prescription Monitoring Drug Program, and became the second state in, I think, 2017, after this one, if I'm not wrong, to pass a strict new opioid prescribing law. As Michael mentioned in his talk, real efforts to expand substance abuse prevention and treatment have been stymied by Maine's Republican governor, Paul LePage, who is thankfully in his last 6 months of 8 years in office. In 2016, and when we talk about othering someone who has substance use disorder, it's not just like random, it borrows from racist discourses and classist discourses and all of those problematic discourses. So when the governor says, guys with the name D-Money, Smoothie, and Shifty, who, quote, come from Connecticut and New York to, quote, sell their heroin, and adds, in case you missed like the racial implications, that they, half the time, this is a quote, I'm so sorry, this is a direct quote, half the time they impregnate a young white girl before they leave. I mean, the whole thing is so problematic on so many levels. This is a state where black citizens are currently incarcerated at a rate of 839 per 100,000, while white citizens are incarcerated at a rate of 140 per 100,000. Our black population in Maine is 1.5% of our 1.2 million people. So you can see how totally inappropriate in so many ways and out of balance, just numerically, things are. LePage likes doubling down on penalizing people with substance use challenges, vetoing funds for needle exchanges, stalling efforts to expand treatment and access to naloxone, and thwarting Medicaid expansion, which would substantially improve many things, until he was overruled by a ballot initiative in 2017. Last year, there were a record 418 deaths from drug overdoses in Maine, an 11% increase over 2016, although actually things have slowed down in Maine in the last 6 months. And I also have to add the caveat that even though 2017 was the worst year for deaths, it wasn't all opioids. What we've seen in my state is the growth of use of cocaine and meth. So those were responsible for an increasing number of deaths. But at the height of this problem, there were 82 opioid prescriptions for every 100 people in the state of Maine. Recently, for an international conference on ethics consultation, a physician colleague and I prepared a retrospective review of 10 years of our ethics consulting at the hospital where we work. We were surprised to see that a lot of the patients that we consulted on were in their 40s and 50s. We expected a lot of end-of-life cases, and those would normally be older patients. Then we looked again, and we saw how many of the cases actually involved substance use disorder in some way or another, and that explained in many ways why most of our ethics consults were on patients in their 40s and 50s. I'd like to talk about a specific case that highlights some of the challenges that Mainers face, and also perhaps how humanities can help approach the opioid crisis. In 2015, an ethics consultation was requested to discuss the situation of a 24-year-old woman, Alyssa. Her name has been changed, and some of the details have been changed to help with keeping the story anonymous. She was living homeless in the Bangor area. She'd come to the emergency department a week earlier, complaining of fever, chills, and shortness of breath. She exhibited malaise and weight loss. She was diagnosed with sepsis and given broad-spectrum antibiotics. She was diagnosed with severe mitral regurgitation with endocarditis, and clinicians determined that she was a candidate for mitral valve replacement, without which she would eventually die. She had a history of IV drug abuse and refused the surgery. She attempted to leave AMA against medical advice. She said her ideal day was shooting up 10 or 15 times a day and smoking. And she asked over and over again for cigarettes. In the meantime, the on-call cardiothoracic surgeon stated that he would not perform a surgery on this patient in any case because she's just going to continue to use, and it won't do any good. Alyssa was described to me as very strong-willed, non-compliant, and determined to get back to her drugs. Look, she knows what she wants. If we don't let her leave, aren't we violating her autonomy? A doctor asked. When we think about morality as an evolving set of social practices and not as a single disembodied theory, we realize that it is itself, as I've already mentioned, shot through with prejudices, blind spots, and ignorance of its own times. The word addict, the moralization of substance use disorder, for example. Both philosophical and common morality tend to really value autonomy. It's a uniquely human capacity, auto, self, nomos, rule, right? The ability to live by your own lights, make your own decisions. It's considered the essential ingredient in personhood on the basis of which we owe one another respect. Basic autonomy, the minimal kind of status for being responsible, independent, and able to speak for oneself is required for moral responsibility. But people who face substance use challenges are caught here. They're simultaneously blamed as if their substance use disorder came out of nothing, right? It's just sort of vacuum created it. But they're also cast as non-autonomous, as slaves to their addiction in the language that's often used. They are just responsible enough, that is, to be very morally bad. But they're not so responsible that they deserve our respect. Okay. So this tends to cash itself out in the clinic, which is a very prosaic kind of atmosphere, as decision-making capacity, right? Bioethics tells us that to respect patient autonomy, we have to respect patient decisions. But patients have to have certain cognitive capacities to be able to be deemed able to do this. So they have to understand the relevant information, they have to be able to communicate a choice, they have to appreciate the situation and its consequences, and they have to give reasons for their treatment options, etc. And this was kind of what drove people to call the ethics consultation service in the case of Alyssa. It's helpful in clinical ethics, though, to think about how is a situation conceived and presented. What shows up as an ethical concern? If we made a TV show trailer of the undercurrents of this case as it was first presented, it would be something like, watch as caring doctors and nurses decide whether to waste healthcare dollars on an ungrateful and unrepentant drug addict. Right? Not to put too fine a point on it. Even the word case obscures the way choices shape the story. Todd Chambers has a great book called The Fiction of Bioethics, where he shows us all the ways that the stories are fictional in an important sense. When an ED doctor's note says, I think we can get away with putting her on the floor instead of the ICU, what is being communicated by, I think we can get away with? Why was that part of the note? In the case of Alyssa, the focus was on her inability to process information and brain fog. These impeded a decision on her surgery. It's a good example of how ill-equipped many hospitals are to deal with substance use disorder. The substance use disorder was seen as just a thing that is in the way of the real thing, which is the surgery, right? To figuring out whether to do the surgery. Alyssa was seen twice by psychiatry where they did not discuss her substance use disorder. They just tried to determine what her global cognitive capacities were. Our substance use disorder isn't physical health, and as we've already seen, it's not mental health, right? So it's sort of nowhere. So you have mental health providers coming in and working with this patient who don't address the substance use disorder. Okay. When I got into clinical ethics, it amazed me how different reports on the same patient could be. I'll take the example of bipolar disorder in Alyssa's case. There's a family history of bipolar disorder with a strong family history of alcoholism. A great uncle and a great aunt have committed suicide in her family related to bipolar disorder, alcoholism, and depression. In addition, her mother said Alyssa was off her bipolar meds. But Alyssa denies having bipolar disorder. There is no record anywhere of a diagnosis of bipolar disorder and no record anywhere of a prescription to help with bipolar disorder. So this is the kind of patchwork that many of these patients come in to the hospital with. A hospitalist note, only one of the notes, stated, trauma history includes assault by her former boyfriend. This seems significant. We know how significant past trauma is for substance use disorder, but it appeared nowhere else. She was also identified in all the reports as a Native American woman, which she was. I have never seen a chart that refers to a white person as white in the hospital. So clearly her ethnicity was considered significant enough to make a note of it. In terms of the opioid epidemic, we know that in Maine, Native Americans are much more likely, some estimates say 5 times more likely, to develop a substance use disorder. But what was done with this information? Nothing explicitly, so why was it noted in the chart? What work is it doing? On the plus side, maybe it contextualizes Alyssa's situation and her background and helps create understanding and empathy. Or maybe it just reinforces stereotypes about Native Americans and about the low likelihood of her recovery. I said I was half joking earlier about philosophy unfitting me for clinical ethics work, and I was half joking because I get a lot out of my philosophical training. I was taught to pay a lot of attention to my words, and so I pay a lot of attention to the words in the charts. I was taught to make sure every sentence is doing some work or get rid of it. So when somebody puts a sentence in the chart, I take it seriously. When a surgeon tells Alyssa, quote, "I did discuss with her and her mother that we would place a tissue valve and subsequent redo surgery would not be feasible if she reinfects her valve secondary to ongoing drug abuse." I wonder whether an orthopedic surgeon would say the same thing to a soccer player who tears his ACL and wants to go back out onto the field. Would they say, "We'll fix your ACL, but if you play some more for Colby and come back with this, forget it. We're not fixing it again," right? So why is it the same with the heart valve replacement? Why isn't it the same? So these are the kinds of questions that philosophy taught me to ask. Where is the consistency there? And if they're morally relevant differences, then we need to tease them out and make them explicit. In our clinical ethics conversation, we learned that there were a lot of disconnects, that Alyssa wanted to leave but refused to acknowledge she might die. I was told she was exhibiting classic denial. She wouldn't maintain eye contact. She said, "Sometimes I wish I would die." And there was a lot of question about whether that was true suicidal ideation or not. But that was the focus. It wasn't, what does she mean when she says, "Sometimes I wish I would die"? What is the meaning of that for her, regardless of whether she meets our clinical definition of suicidal? When I visited her, I expected a force of nature, but encountered a skinny woman agitatedly scratching track marks up and down her arms and on her neck. She was moving her head back and forth on the pillow, clearly unhappy with her nasal cannula. She was able to answer a few questions, but unable to sustain meaningful conversation for a prolonged period of time. I did learn that she had suffered a series of tremendous losses in the last 18 months. She lost her job at Walmart. Homelessness is tough for maintaining a job. She lost her boyfriend, and her dog died. She had only been on IV drugs for a year and had never had treatment. I began to appreciate why she might find it difficult right at this moment to think clearly about her future. She said she had pain all over and needed something for it now. So once we all got together to share our perspectives, a pretty clear picture emerged of someone whose life had spiraled pretty quickly out of control. Instead of terms like poor insight or refused or unable or non-adherent or agitated, maybe we could make an effort to tell a different story. Alyssa was right when she said, as she did, quote, "This is happening too fast. I don't have time to think." Okay. She walked into the ED with a foot swell and pain, and then she was told within hours that she had to have life-saving surgery or she would die. I think for any of us, that is going to be an extremely disorienting experience. If another patient said, "This is happening too fast, I don't have time to think," I don't think we would blame something else. I think we would say, yeah, that makes sense. She had asked for support in making the decision for surgery, but her mother refused to help, and she was still waiting for some support. She felt she would let everyone down if she had a heart valve replacement and didn't take care of herself afterwards. She suffered from shame and low self-esteem. Now, her belief that she couldn't recover was pretty rational, given that she had never experienced treatment. She couldn't even imagine it or conceive of it. Her fear of surgery was rational too, because we know, and she had heard from her friends on the street, what happens when people with substance use disorder have pain. It's often undertreated, especially post-surgical pain, because they can tolerate a lot, they need a lot more of the drug to get the same relief in many cases. Jeez. She's learned about how to live as a person with a substance use disorder, but she knows very little about recovery paths. From her perspective, maybe getting high 10 times a day is preferable to any other live option she can currently conceive. One of the surgeons wrote, he talked with the patient in front of the patient's mother and mentioned he does not think the patient is an operative candidate given her history of drug abuse, and she's going to do poorly with surgery and is going to have a poor recovery. Okay, there's some hope and optimism right there. And yet the patient is the one that's having a hard time planning for the future? On what basis would a surgeon make this determination for this patient? It would be easy to sit here, though, and I'm doing it, I know, and criticize the doctors. I could identify their unsupported decisions and I can apportion blame, but in clinical ethics consulting, I'm consulting for everyone. Everyone's upset about this case. We need to understand everyone's story, not just the patient, because the point is to be helpful, not right. What experiences has this physician had in the past, as we've heard, with patients with substance use disorder, with his family, with his self? It is, in fact, more harmful and painful to have the surgery and reinfect the valve than to try to get along and deal with endocarditis with IV drugs. Antibiotics. Right. When the ED doctor tries to keep Alyssa on the floor, he is responding to legitimate needs to give the appropriate level of care and not divert resources that could be needed for another patient in the ICU. When a nurse takes a caustic attitude to a patient who wants to go home and get high 10 times a day, we can consider the fact that moral distress and burnout are the leading drivers of nurses leaving the profession, and we can talk about how in Maine and many parts of the country we have a real nurse shortage. She's experienced a kind of learned hopelessness about patients like Alyssa, who she will see again and again until she doesn't, in her mind. So there's so much more to be said, and I've already gone a few minutes over. I'd like to close with another way that philosophy has helped me work with patients and staff in situations like Alyssa's. Basic autonomy is important, ethically, medically, legally. We do need to let patients who can make decisions make them for themselves, right? It is important. We don't want to run roughshod and be paternalistic, but we have to do more. We have to actually support a robust form of autonomy. We have to help patients where they're at. We can't just come in with a checklist about decision-making capacity and put them in one box or the other. Right? So we have to do more. Our job is to help her aspire, think of a life that she can aspire to, and according to which she can be maximally authentic and free of distorting influences. We'll help her regain her decision-making capacity about the surgery, and that is pressing and it is important. But as humanists, we can recognize that being autonomous implies a measure of self-worth, in that we must be in a position to trust our own selves and trust our own decision-making capacity, to put ourselves in a position of responsibility. To be autonomous is to be one's own person, to be directed by desires and conditions and characteristics that are not simply imposed externally, but are part of what can somehow be considered one's authentic self. To be autonomous is to write and tell one's own story. Thank you.